Dear Chairman, dear professors, we are going to talk today about the mitral tear for low and intermediate risk patients. It's a hard question to answer. Yani, if I just started, it was in 2014 when I started my mitral clip program. The guidelines, what did it say in 2014? And at that time, it was a 2B classification recommendation from the American Heart Association, and it was only restricted. It was only limited to the patients, severely symptomatic patients with severe mitral regurg who are not eligible for surgery. What changed in 2021 from in the guidelines? We have now secondary mitral regurgitation recommendation, which is still 2A for the patients who are also not eligible for surgery, and it's 2B for the patient who doesn't have the criteria for the co-opt criteria. Yani, when the patients have a severe pulmonary hypertension, severe reduced ejection fraction less than 20%, they are not capable also to be candidates for mitral clip. What about the primary mitral regurgitation? You will have also a closed door. It's 2B classification, also considered only for symptomatic patients who fulfill already the echocardiographic criteria of eligibility, and they are inoperable. They has to be inoperable. So this is what the guidelines say until now, until 2021. This is the last guidelines for the valvular heart disease. I tried to make the story short, so I looked on the web. There are only one publication for the TEER, for low and intermediate surgery patients for the degenerative mitral regurgitation, and this is still not recruiting this study. It will be recruiting soon. Maybe it will answer a part of the questions, the primary ME. But what we have now in 2024, we have 20 years of mitral clip. We have an experience of 200,000 patients in 1,000 centers. So we have a lot of experience. We have a fourth generation. We started in 2003, which was generation 1. At that time, or at 2012 or something like that, they did it what is called zipping by clipping. They used to do 5, 6, 7 clips in a patient because the clips were so small. But now in 2019, we have 4 different clips. We have a wide clip, a long clip, and then a small clip and a thin clip, with 4 millimeter or 6 millimeter and until 12 millimeter in the length of the clip. We also have the Pascal system and the Pascal S system, which allows us to try more and more patients. There is not a big difference in the method, but it's all depends on the mitral tear or the edge-to-edge repair, like the Alfieri stitch, but it helps us also. What about the scores? Well, we have the STS score, we have the Euro score. What's going to help us? There's actually, we don't know if the scores help us. We will see this also. There's one publication which compares this patient for the mitral repair patients, and actually this is, both didn't predict the mortality in the mitral clip patients. What about the heart team? We have a cardiologist who have the experience in the mitral clip procedure. We have a cardiac surgeon. We have a cardiac anesthetist. But we always forget about the patient. What's the patient? The patient has to be a part of this heart team. He has to be. What do you want to do? The problem, what we see today nowadays, that the patients are always old patients. They are above 80, above 75, and so on, and so on. If we go to the real life patient, what we are doing? We are going. So I went in our database. I chose the first patient is an 80 years old female patient, a German patient. She was presented at our clinic, and we can see here that the STS score 2.6 and the Euro 1 score is 8.4. Actually, a low risk patient, but she lived next door to the cardiac surgeon actually. And our cardiac surgeon called us and told us, can you please do this patient a mitral clip? She's 81 years old. She's fit, but she's 81. She will not benefit from the open heart surgery. Please do it with a clip. So she has this jet. She had some cordial rupture a little bit. This is a 3D, which you can't notice. You cannot notice this, and this is after the clip. Minimal mitral regurg or grade 1 mitral regurg. Actually, she had also a tricuspid regurg, and we also 3 months later she still had the severe tricuspid regurg. We also clipped the tricuspid regurg. The patient is still doing fine for 3 years now. The cardiac surgeons are also satisfied for this. If we go to the second patient, he's actually this patient was presented to me. He was 51 years old at that time. He was actually an Egyptian patient. He had a anterior myocardial infarction. He had a ejection fraction 35 to 40%. But if we see what the score said, we have a ST score from 5.1, which is about intermediate risk. We have a neuro score 145, maybe also intermediate risk. The patient had aortic insufficiency grade 1 to 2. He has also pulmonary hypertension, and he had thoracospid insufficiency 2 to 3. So actually, this patient showed the first surgeon. He was a very nominal surgeon in Egypt. He went to him and he told him, "We'll do a hit and run technique. Just the mitral valves. That's enough for you. You will gain a lot from this." I don't know. Another cardiologist said, "No, this will not enough. Go to Germany." So he went to the second cardiac surgeon in Germany. He told him, "You have to listen to me. Just keep the money for your children. You don't have to keep it. Don't do this. You will die on the table." So his cousin is a spinal surgeon. He called me and he said, "Do you have a do you have an option for him?" I told him, "Okay, send him to me." Actually, 51 years old is at that time, it's a very hard. We never did it. So I called the third surgeon. He is a friend of mine, and I told him. He told me he will go to Egypt in a box, or he will go to Egypt on a wheelchair after 10, 20 days in the intensive care, and he will pay a huge amount of money. So I'm not touching him. So we decided to do a mitral clip at that time, and this is his mitral insufficiency. You can see this. At that time, the patient couldn't walk even 50 meters without arrest, a severe mitral regurg. And he has if you see the anterior mitral leaflet, there's some rheumatic involvement, we think, because the anterior mitral leaflet is not really mobile. So he has a gradient of 2 millimeter mercury in rest, and the mitral valve area was in the core lab was only 3.9, which is actually a contraindication for mitral clip. But we decided to do him. He doesn't have anything option. That's the clip. We can see here. We are closing the clip. At that time, it was only an XTR. There was no XTV at that time. And we can see here the result after the clip from a torrential mitral insufficiency with one clip, XTR, to a grade 1 with this pump function, which is 35 to 40%. We accepted it. The gradient was about 4 after that, so we refused to put another clip or the second clip next to it. The patient on the next day, he kept moving from the ward, from the first room to the second ward, about 1 kilometer without arrest. His renal function was really dried. His renal function came from 1.8 to 1.0 only through the infusion during the procedure. And he's doing fine until now, 5 years. He has a 5 years follow-up. He's doing really fine. He still has the pulmonary hypertension actually went down from 50 millimeter mercury to 40 millimeter mercury. He's doing really fine. He's satisfied. He is thankful. What about the third patient? We have the third patient who's also an 81 years old. He also had an STS score from 3.7 and an Euro score 1 from 5.2, a low-risk patient actually. But this patient has a primary mitral ME with a clear flail mitral actually. If you see the insufficiency, the eccentric jet, and the 3D, it's actually heroic. The patient was actually not too bad situation. He's low risks, but so we referred him to surgery. The surgeon accepted him, the cardiac anesthetist accepted him, but the patient said, "No, I'm not going to do it. Leave me alone. No, I'm not going to open my chest." We talked to him about the minimal invasive MEC technique and all about this, but he refused. Nobody. He will just try the percutaneous. So we put him 2 clips, and you can see him. It's really a severe improvement. It was not done. You can see the eccentric jet, but in this primary, Dr. Osama will talk, I think, about this issue, what the criteria. But we can also see the tissue ridge in the 3D pictures, and in the core labs, the rest of the mitral insufficiency. He did well after that, and I don't know about him actually. Patient 4, still a patient. He's 55 years old at that time. But if we see the discrepancy between the scores here, with an STS score from 2.3, but the Euro score is 20, about 20, 19%. Severe description, because he's 55 years old, but if you see here, he was about 2 meters long and 200 kilograms. And that's the difference, and that makes the difference. He was diabetic, he had ejection fraction from 20, 25%, and sure, no surgeon will touch him. He will have no. So he asked us to do this. He has here's 1.3, he has this mitral insufficiency. That's the result after 2 clips. Actually, the patient is doing very fine. He went back, he lost about 20, 30 kilograms after that because he increased his exercise. He went back to his life. He was a lorry driver. He assumed his life, and he was also thankful. That's all. So he didn't, that's about, maybe I didn't bring the gradients, but we always measure the gradient after the first clip. If the first clip is enough, like the Egyptian guy, if it's 4, we'll not do a second clip. But I think we went here with 2 to 3. And you can see here, Dr. Osama, the 2 openings. Sometimes we do a mitral valve area for the 2 openings, and we calculate it to exclude that as a mitral stenosis. But he's really doing fine, the patient. And that's the gradient here, 4 millimeter mercury. So it's accepted, really accepted. So the question was still, are we there yet? I think we are there. We can do it in selected patients. The financial problem will stay actually in our way, but we are there. We are ready to treat it with this a lot of options, and a lot, especially in the secondary MI, where most of the surgeons are now taking a step back and leaving us do the mitral clip. Thanks a lot for your help. Any question? Mitral stenosis, we cannot touch it because we will make a more stenosis. If it's aromatic stenosis, ischemic, you can do it. If it's eligible for the criteria. ما coronary stenting يعني لو هو he is treated for coronaries or not.
coronary stent مع
هو لو 3 vessel disease and severe mitral regurgitation guidelines say operation. هي الفكره يعني the most problem يعني ان هو دلوقتي العيان بيجي عنده 80 82 سنه. هو او 85 سنه او 88 سنه. Who is going to put him on a surgeon, cardiac surgeon who will put a 85 plus patient or 80 plus patient for a CABG plus mitral valve repair? Ischemic time will be he will surgical risk is very high.
نعمل الميترال مع الستنت.
No, we don't do it. عشان in Germany you will lose your job if you do it in Germany. We can do it عشان ما فيش contrast في الميترال clip. We can do it, but we usually don't do it علشان ال financial burden. This is another session. And if it's really ischemic and he has لو عنده CTO بس عنده vital myocardium, you have to treat the coronary vessel. You have to leave him for 3 to 6 months to take his medications. And if it's the mitral insufficiency is better, you don't have to clip him. So you have to treat the cause first.
Thank you very much. This is the German experience يعني كويس. بس انا ملاحظ ان كل العيانين بتوعك برايمري.
هو اول واحده عشان الصدق يعني احنا ما شفناهاش برايمري لانها جوه، احنا كنا شايفينها سكندري خالص. الحته الرابتشر كود الصغيره دي احنا ما شفناهاش بري اوبريتيف خالص.
يعني قصدي I think there is a big difference between secondary and primary. يعني what you saw is the marvelous effect in the primary. The secondary I think it will be another story.
هو السكندري is more easier. المشكله في السكندري is the follow up after the remodeling. We don't have هو ما فيش predictions. هي دي المشكله ان هو آه.
البتاع ده مكفي عليا شويه، ممكن نخليه كده. طيب. اوكي، بعد الاستعراض العظيم من دكتور احمد فرح هنتكلم على اتكلم على الميديكال تريتمنت فيرسس الترانسكوتينيوس ايدج تو ايدج ريبير. ما بيقلبش من عندي ليه؟ هو ممكن بدايه مثلا بالريموت. طب mitral regurgitation can be broadly classified into two different categories: the primary and secondary mitral regurgitation. Evaluation, treatment, and prognosis in patients with these conditions differ. فرق كبير قوي ما بين البرايمري والسكندري. Secondary mitral regurgitation is common in patients with heart failure or coronary heart disease. It is present in about 50% of patients after myocardial infarction and more than doubles the mortality risk. Anatomy of the mitral valve apparatus is very complex, as we see the mitral annulus, the leaflets, the chordae, papillary muscles, and the myocardium. In secondary mitral regurgitation, the problem is the balance between the tethering forces and the closing forces. When there is left ventricular dilatation, بيحصل displacement of the papillary muscles toward the apex، وده بيشد على الكوردي تنديني، وده اللي بيؤدي الى tethering of the valve leaflets. في نفس الوقت المyocardial contraction is weakened, so the closing force is weakened. So it is imbalance between tethering forces and the closing forces. كمان secondary mitral regurgitation is quite variable. يعني you should record the heart rate والblood pressure if there is any arrhythmia during recording, and it may increase with exercise. Sometimes the patient experiences symptoms only during exercise because the mitral regurgitation is exaggerated with exercise. So in management of secondary mitral regurgitation, we have the guideline directed medical treatment. You manage left ventricular dilation and remodeling by guideline directed medical therapy and CRT, sometimes revascularization, and with the transcutaneous edge to edge repair if there is leaflet malcoaptation, and surgical annuloplasty or AF ablation may reduce the severity of mitral regurgitation. القاعدة ان optimal medical therapy should be the first and essential step in the management of all patients with secondary mitral regurgitation, and should include replacement of ACE inhibitors or ARB with second-trial valsartan, sodium glucose cotransporter 2 inhibitors, and or ribavirin whenever indicated. Indications for cardiac resynchronization therapy should be evaluated in accordance with related guidelines. يعني always في secondary mitral regurgitation the problem is not the valve itself, it's the myocardium, it's the ventricle. So the patient should have proper medical therapy, should attain the maximum tolerated doses of all four pillars of خصوصا السكند valsartan, and if this therapy is ineffective then we refer the patient to TER. وهنا بنشوف الانسيستوليك فوليوم left ventricular وانتاستوليك فوليوم decreased significantly with carvedilol in heart failure patients with reduced ejection fraction. Also, sacubitril valsartan improved the volumetric remodeling in patients with heart failure, which was associated with improvement of mitral regurgitation. هنا شايفين بالvisual severity grading, and definitely mitral regurgitation decreased. يمكن دي من الترايل اسمها برايم ترايل. بنشوف هنا البيشنت في الابر بانل بيفور الانيشيشن اوف ساكابتريل فالزارتان كان البيزا كانت 0.9 افتر انيشيشن اوف انترست او البيزا قلت، وبرده الافكتيف الريجاجنت افكتيف اورفيس اريا نزلت من 0.32 ل 0.1. فريلي الميديكال تريتمنت وركس. كمان الصوديوم جلوكوز كوترانسبورتر 2 انهبيتور تريتمنت significantly reduced the end diastolic volume والend systolic volume والايجكشن fraction increased. فاذا we have the four pillars of heart failure therapy which should be initiated and maximized to the maximum tolerable dose for patients with heart failure and secondary mitral regurgitation before referring them to transcutaneous edge-to-edge repair. كمان we don't forget the cardiac resynchronization therapy for secondary mitral valve whenever there is indication, whenever the patient is indicated. As you see the baseline, there was significant mitral regurgitation which was significantly reduced after cardiac resynchronization therapy. We have two trials for transcutaneous edge-to-edge repair. أول واحدة الميترا French investigator, it was a total failure. There was no significant difference between the control group and the intervention group. The second trial, COAPT trial, was surprisingly in the same year, in the same journal, New England Journal of Medicine, a completely different result. كانوا حوالي 614 عيان randomized to device therapy and control group. وزي ما احنا شايفين الريزلتس كانت stunning بالنسبه hospitalization for heart failure significant reduced and total mortality was significantly reduced وال safety of the procedure was الحقيقه كانت كويسه جدا. There were no problems. طب ايه الديفرنس؟ Why the difference between these two pivotal trials? The severity of mitral regurgitation. في الميترا French trial enrolled patients with less severe mitral regurgitation and ventricles were more dilated in the Mitra FR patients. كمان significant exclusion criteria in the COAPT trial, they excluded stage D heart failure, end systolic dimension above 70 millimeter, moderate. الصورة راحت عندي. أيوة. Moderate to severe right ventricular systolic dysfunction and pulmonary artery systolic pressure above 70 millimeters mercury. The COAPT trial also emphasized that maximally tolerated guideline-directed medical therapy compared with the Mitra French trial before consideration of enrollment. Finally, the residual mitral regurgitation was more frequent in Mitra FR compared with the COAPT trial at 1 year. ويمكن الصوره دي بتوريني الديفرنس ما بين التو ترايلز. الديسبروبورشنت mitral regurg اللي هو على الشمال الفنتريكل از مور elliptical والeffective regurgitant orifice is greater. على الرايت سايد ده البروبورشنت mitral regurg الفنتريكل is spherical, there is global hypokinesia and mitral regurgitation is proportionate, severity is proportional to the left ventricular enlargement. أتوقع إن the patient on the left side will benefit much more than the patient on the right side. ال 5-year follow-up ده لسه منشورة في New England Journal of Medicine June 2023. 5-year follow-up of those patients can still benefit there. الهارت فيلير هوسبيتاليزيشن زي ما احنا شايفين 33.1% في الديفايس جروب versus 57.2 في الكنترول جروب. الديث from any cause still significantly lower في الكنترول في الديفايس جروب 57.3 versus 67.2. لكن لما نيجي تاخد الكومبايند اند بوينت بقى اللي هو هارت فيلير هوسبيتاليزيشن اند ديث هتلاقي في الديفايس جروب is 73.6 versus 91.5% في الكنترول جروب. يعني صحيح في significant difference لكن after 5 years تقريبا اكتر من تلتين العيانين في الديفايس جروب they either died or were hospitalized for heart failure. فلازم نفس البروسيدور دهيا it's not cure, it improves symptoms. اكيد في الشورت ران بتقلل المورتاليتي لكن هنا الوضع بيختلف عن التابي. التابي ده problem in the valve. Once you fix the valve البيشنت غالبا بيمشي كويس. لكن always think in the secondary mitral regurgitation it is disease of the ventricle. is not disease of the valve. لكن صحيح احنا لما بنقلل الميترال ريجرجيتيشن اكيد الهارت فيلر هوسبيتاليزيشن بيقل والمورتاليتي بتقل، لكن تيجي بعد 5 سنين ده في الكواب ترايل ان almost 74% 3/4 العيانين either died or had heart failure hospitalization. So caveats about the COAP trial, CLEEP therapy is no panacea. Panacea بالعربي يعني ما هيش وصفة سحرية. At 5 years, nearly 3/4 of patients treated with mitral CLEEP had died or been hospitalized for heart failure. Those sobering event rates notably were lower in the device group than in the control group, أكيد, where more than 9 out of 10 patients had been hospitalized for heart failure or died. There have been some big changes in guideline-directed medical therapy for heart failure since COAPT, namely sacubitril valsartan and the SGLT2 inhibitors, two amazing additions to guideline-directed medical therapy that heart failure specialists now have in their armamentarium. دول ما كانوش موجودين وقت الكواب ترايل، لا الساكابتيل فالسارتان ولا الاس جي ال 2 inhibitor. وهنا come the question, do we need a redo of COAPT in which all patients were optimized first on 4-pillar heart failure therapy and cardiac resynchronization therapy as needed? So the heart team هنا زي ما قال دكتور احمد فرح is very important. The importance of decision making by a multidisciplinary heart team needs to be emphasized in this setting. The heart team, including a heart failure specialist, should optimize guideline-directed medical therapy and consider the indications of electrophysiological, transcatheter, and surgical interventions, their priority and order of implementation. الجايدلاينز واضحه قوي، اللي هو بقى patients with heart failure, severe secondary mitral regurgitation, and coronary artery disease who need revascularization, CABG زي ما قلنا, and mitral valve surgery. Percutaneous edge-to-edge mitral valve repair ده class 2AB should be considered in carefully دي مهمة قوي selected patients with secondary mitral regurgitation not eligible for surgery and not needing coronary revascularization, who are symptomatic despite optimal medical treatment and who fulfill criteria اللي هي الكوابت criteria for achieving reduction in heart failure hospitalization. وبرضه الامريكان جايد لاينز هي بتعيد نفس الكلام، ويمكن ده الالجوريثم فور التريتمنت اوف mitral regurgitation. انا مش هعيد لان انا قلته قبل كده. والconclusions in the secondary mitral regurgitation is first a disease of the myocardium, and that's more where we should act not on the mitral valve. Guideline directed medical therapy is the first line approach in the management, in the treatment of patients who have heart failure with secondary mitral regurgitation and a reduced left ventricular ejection fraction. Surgical or transcatheter intervention should be undertaken only after the patient has received the maximal dose of medical therapy without adverse events. Thank you.